Philadelphia International Medicine, PIM, provides international patients and physicians with access to an unmatched network of world-renowned doctors, surgeons, and hospitals that deliver personalized medical, surgical, and rehabilitative care ranked among the best in the world. Since 1999, Philadelphia International Medicine has helped patients and physicians from around the globe eliminate the guesswork, planning, and anxiety of finding and connecting with doctors and hospitals ranked among the best in the world. With 8 hospitals, 2 medical schools, 2 cancer centers, and hundreds of top doctors, only PIM can bring you into its medical family with one easy phone call or email. Thanks for joining our presentation. Philadelphia International Medicine's Global Education Media Program is a monthly digital platform that invites physicians from around the world to exchange knowledge and innovative uses of medical technology, review the latest advancements in research and clinical care, and share best practices in case reviews. To contact our presenter, refer a patient, or more information, email physicians@philadelphiamedicine.com. Follow PIM's YouTube channel for more educational videos.
Thank you very much for having me. My name is Henry Fung from Fox Chase Cancer Center. Today I'm focused on cellular therapy for multiple myeloma and lymphomas. This is Fox Chase Cancer Center. At night, it's beautiful. Philadelphia is beautiful. Come to Philadelphia. The first topic, we'll focus on autologous stem cell transplant for newly diagnosed multiple myeloma. So multiple myeloma treatment now has evolved into different phases of treatment, not just one chemotherapy. When you fail, get a second line, get a third line, and now we have a comprehensive program for each patient. And starting with what we call the induction therapy and consolidation and maintenance. Used to be the multiple myeloma has a median survival in 2.5 years. Now, with the current treatment with induction consolidation maintenance, is up to 8 to 9 years with a median survival. The overall outcome has improved significantly. And this is due to the more effective novel therapies with novel agents, including IMiD, immunomodulating agent, and proteasome inhibitors, followed by autologous stem cell transplant, in particular after transplant using maintenance therapy. So why we do stem cell transplant? As you know, stem cell transplant has been used for more than 50 years, and we understand higher dose is better. So we use big guns to try to eliminate all the cancer cells. And but at the same time, this potentially will eliminate the normal bone marrow and stem cells. The normal stem cells make red cell carrying oxygen, platelet for clotting, immune cell for fighting infection. Therefore, we must have a mechanism to preserve those stem cells. That's how stem cell transplant come out. We extract the stem cells, give the patient high dose melphalan, effective, very effective chemotherapy agent, and then we infuse the stem cell back to the patient. In fact, we should call it a stem cell transfer, because when we are talking about transplant, like I give my kidney to you, then this is a real transplant. There will be a rejection. But using the patient's own stem cell, there's no rejection. This is autologous stem cell transplant. It is used for multiple myeloma, specifically for newly diagnosed patients, based on the 2 major studies, one from the French group, from Dr. Tell, which showed that using high-dose chemotherapy has a event-free survival and overall survival benefit. Followed by the British studies, again showing the same thing with progression-free survival and overall survival benefit. So patients live longer, better quality of life. So autologous stem cell transplant was established as the treatment standard of care for patients with newly diagnosed for multiple myeloma based on these 2 landmark studies. Since then, the multiple phase 3 randomized study has been completed. Not every single study show a overall survival benefit, but all of them basically showing that a progression-free survival benefit. In other words, better disease controlled. And there's a question why, if this is only a progression-free survival benefit, why we are doing it and why we don't have overall survival benefit in every study. A few very important things to mention. One is the timing of a transplant. So if the patient can receive a transplant at a later stage, then this is still a transplant. The patient can have a second-line treatment, third-line treatment with a transplant or with all the new agents. There's so many new agents has been developed over the past few years, in particular in America, that we have multiple agents approved by FDA over the past 18 months. So if you have more effective treatment after they fail transplant, then to see an overall survival benefit is much more challenging. And as I have said earlier, now a median survival for patients of multiple myeloma is up to 8 to 9 years. You take a longer follow-up to show a survival benefit. So 2 or 3 years in the past, you can show a survival benefit and it's no longer happened anymore and is good for our patient. So let's talk about a late transplant strategics. We can have a patient with newly diagnosed multiple myeloma. We treat them with induction, and maybe we collect the stem cells and then transplant them at the first disease progression instead of upfront the transplant. That has been done for other heme malignancy. The study is addressing whether we should do frontline or we can do a rescued treatment. The survival, in fact, again, early and late are the same. This is back in 1998. But let's say interesting observation is time without symptoms treatment or treatment toxicity, what is called TRIST, showing that basically it's better quality of life, less mobility when the patient receives a upfronted early transplant. Multiple myeloma is a disease of I call it older patient population. The median age of diagnosis is around 68 to 69 years old. 1 year older is 1 year older. If the patient has a first response of 2 or 3 years with chemotherapy without a upfronted transplant, 69 years old at diagnosis, 3 years later is 72 years already. 1 year older is 1 year older. The body is, all the organs are 1 year older. At the same time, multiple myeloma is not a colon cancer that affecting the colon, breast cancer affecting the breast. It's a systemic disease. In particular, they have many devastating complications. In particular, bone event. If a patient that has progression within the 2 years, we think they can just be a transplant candidate, but then with the mobility, they fracture their bones. They have acute renal failures. They may never be able to go for a transplant. So an earlier transplant had the advantage, major advantage of improving the quality of life and avoiding all these mobility at the time of disease progression. But when we're talking about these phase 3 study and all the studies that I just have discussed, they are more in the 10 years ago or 20 years ago. Why? Because all phase 3 randomized studies take a long time to accrue patient, design the study, and then waiting for the adequate follow-up to show the difference. And during this time, all the novel agent has developed, as I have mentioned before, which including the immunomodulating agents and also the proteasome inhibitor. To address this, this is one of the landmark study just published in New England Journal of Medicine. How about we use the most effective induction regimens and then just continue the treatment? This is what we have been using in United States, RVD. RVD composed of image with Rapamid or lenalidomide. R, V is Velcade and dexamethasone, and compare with a transplant. So this is the RVD arm, the novel agents arm, that are also followed by maintenance. And here you have the induction consolidation with a autologous stem cell transplant, followed by 2 small cycles of RVD and then maintenance. So the study is trying to see if we can do a delayed transplant, not just transplant and no transplant. For patients who fail RVD, most of them also go for a transplant. So there's no study, in fact, has compared BMT and no BMT. They're comparing only the delay strategics. Here show that for the transplant group, more complete remission, more very good partial remission, basically more response. In particular, it's very important is more negative MRD. MRD is minimum residual disease. In fact, they are now very good data showing that the goals should be achievement of a negative MRD. This could be a potential cure for patient who has achieved a negative MRD. And definitely it has been shown to in patient live longer and better disease control if they have negative MRD. In the study comparing RVD only and transplantations, median follow-up about 3 to 4 years, and the 4 years progression-free survival 35% compared with 47%. Transplantation group is better with a hazard ratio of 0.69. That means a 31% improvement in outcome, and with a p-value to very significant, less than 0.01. But as you can see here, the median follow-up, in fact, is still relatively early for a disease with a median survival of about 8 years now. This is only 3.5 years to show a survival benefit, which has not been shown here. You need a few more years to see if there's any survival benefit. Different stages benefit, different risk by cytogenetics benefit, but they have still remain as a poor prognostic factor. So overall, the conclusion from IFM, the French group, 2009, is a 31% reduced risk of progression or death by doing a upfunded transplant instead of waiting for disease progressions, and improve time to treatment, second treatment, and rates of MRD negativity, and both arms has very low mortality. Stem cell transplant in the early days, 40 years ago, or even when I first started to do my first bone marrow transplant back in 1988, it is associated with significant morbidity and mortality. But nowadays, doing an autologous stem cell transplant for multiple myeloma, the estimated treatment-related mortality is less than 1%. In the past 4 years, keep our finger crossed, at the Fox Chase Temple bone marrow transplant program, we have performed approximately 250 stem cell transplant for multiple myeloma. We have not lost a single patient. So longer follow-up required to make any conclusion about overall survival, as I indicated. And despite all the novel agents, a present study showing that autologous stem cell transplant should remain a standard of care for eligible patients with multiple myeloma. So this is this is what we don't know, and we know that autologous bone marrow transplant is an important component for treatment of multiple myeloma. Should everybody be collected upfunded while they want to go for a transplant or not? Yes, I think everyone should have their stem cell collected before any treatment damaging the stem cells. And it would be great to cryopreserve the cells, because when we cryopreserve the cells, we can keep it for up to 10 years. How much? We can do 2 transplants. We're not going to do 2 transplants, but we can easily get enough cells for 2 transplants. We can do it now or do it later. And who should undergo upfunded transplant? The question directed to a transplanter, as I said at my conflict of interest disclosure, will be, I'm a transplanter. Of course, everyone should be transplanted. So autologous stem cell transplant definitely improve progression-free survival. And the mobility at the time of progression can be devastating, as I have mentioned earlier, pathological factor, acute renal failure. So I think everyone should be assessed for autologous stem cell transplant when they are first diagnosed to have multiple myeloma. And definitely, I think a delayed transplant will not be recommended if the patient cannot achieve a partial remission. I think a very good partial remission may not be adequate. I think the higher quality of response will be better. And this will predict for better survival. And the goal has changed not to control the myeloma. We should have a bigger goal now. We should set our goal to long-term survival with excellent quality of life and potentially cure of these patients, although we cannot call a cure for now yet. But think about this, if a patient is 75 years old, undergoing a stem cell transplant, controlled for 10 to 15 years, yeah, it's like almost close to 85, 88 years old already. That's an excellent control. And low-risk patient, what do you mean by low-risk patient? Normal cell genetics and stage 1-2 disease. How about these patients? I think they're still looking at the data. They also benefit from the transplant. The only patient that I really would not consider transplant is they become MRD negative. I think a complete remission is not adequate. And then I think there will be new definitions of the response criteria by International Multiple Myeloma Working Group soon, and MRD negativity will be included in the response criteria and definitions of the response. And this is evolving things, is about how we treat our patients is beginning, we call it precision medicine, based on cytogenetics, using molecular profiling, and using FISH, using cytogenetic genomic analysis, and a risk stratification treatment for patients. Well, who is eligible for transplant? We talk about this is the older patient population. Age is not a very good assessment of a physiologically the patient. Look at this young man who is 82 years old. He looks so robust, look better than me, stronger than me, but he's 82 already. And this guy is like a normal 82, and this guy, unfortunately, is institutionalized as 82 too. So just by physiological age, we should not base on a physiological chronological age to determine who is eligible for transplant. The oldest patient we have transplant, it was a 82 years old patient with recurrent diffuse large B-cell lymphoma. And as you know, there's no any curative treatment for these patients when they relapse, in particular older patient. And he underwent a autologous stem cell transplant about 6 years ago, and now he is in complete remission and alive and well. He's 88 years old with 18 great-grandkids. So just by age, we should not exclude a patient. More important is comorbidity. Comorbidities including other, mainly like coronary artery disease, COPD, history of stroke, autoimmune disease. And all these comorbidities is more important in the performance status of the patient, not just by the age. As you can see here, the 100-day mortality after transplant, the most important is what we have the comorbidity index, a complex index that we calculated, but overall reflecting the functional status of the patient, not just the age group. Interestingly, this is the US data that showing that the multiple myeloma patient, in fact, stem cell transplant is really underutilized, even in the United States. Less than 50 years old, as you can see, about 50% patients undergo a autologous stem cell transplant at diagnosis. Ooh, 50 to 64 already dropped to like 30%. And greater than 65, even in the United States, less than 10%. So this is a standard of care, but the patient assess and the myth about the toxicity of the transplant still make this treatment not widely used even in the United States. And also maybe, as I said, when the patient is eligible during the early diagnosis, at the time, but then they have other comorbidity developed with their aging, with their heart problem, lung problem, they may not be able to undergo its transplant at the time of disease progressions. So high-dose melphalan is one of the most active agents in multiple myeloma. 40 years ago, same as today, the most effective agents. In my humble opinion, this treatment should be included for every patient with multiple myeloma. By itself, 30 to 40% complete remissions, and 34 months of median remission duration without maintenance. And just name another agent with similar single agent activity, we cannot find another agent that's better than melphalan as a single agent. And it's cost effective. Stem cell transplant used to be very expensive treatment, but nowadays with all the new agents, in fact, the new agents are much more expensive. Also considering the comorbidity and multiple relapse treatment, those are even more expensive. And with stem cell support, it is safe to older patients without comorbidity. And not planning for its use upfront is similar to telling a patient, I am never going to use Rituximab or lenalidomide during your disease course because I don't like it or I don't believe in it. So the patient should be considered for an autologous stem cell transplant as part of the treatment for multiple myeloma. Some may benefit, some may not, and but they should be assessed by a transplant physician if possible. So we used to be very arrogant being a transplanter. We do a stem cell transplant and we are done. But when we look at the development of hematology, heme malignancy treatment, beginning learning from the children, acute lymphocytic leukemia treatment always have induction, consolidation, followed by maintenance. Decades and decades from St. Jude Children's Hospital, making ALL uniformly fetal before now is like 90% of children cure of acute leukemia with acute lymphocytic leukemia. And look at acute promyelocytic leukemia. Again, induction, consolidation, maintenance. And then look at follicular lymphoma with all the new monoclonal antibodies, maintenance. And then multiple myeloma is another disease, even after stem cell transplant, maintenance, in fact, is important. One of the reasons that we don't do maintenance after stem cell transplant is because the patient is recovering from a transplant. It could be very toxic if we give them chemotherapy. That's true. And also we give them chemotherapy, very high dose already during the transplant, during the preparation. Why are we giving more? That's why it's not very useful. But nowadays we have these novel agents. These novel agent immunotherapy, they are not chemotherapy. And then our patient recovering very rapidly after autologous stem cell transplant for multiple myeloma. Usually, in about 50% of the stem cell transplant center in US, even performing stem cell transplant as an outpatient treatment. For inpatient, usually lasts for less than 2 weeks, and they recover within 4 to 6 weeks, more than 90% recovery. So it's a rapid recovery, so that's why we can consider maintenance. And this is the first study, one of the first studies using Rituximab. We showed using as a maintenance, improving progression-free survival and overall survival. This is lenalidomide using a IMiC for maintenance. Again, this is a very good data showing both progression-free survival and overall survival benefit. So what am I doing for my patient? Currently, if a patient see me at Fox Chase, newly diagnosed patient, we give RVD for 4 cycles as induction. And then we do stem cell mobilizations. And then we will do autologous stem cell transplant for them. We may even consider tandem autologous stem cell transplant for very high-risk patients with 17p or p53 mutated myeloma cells. And these are based on the HOVO65 data, long-term follow-up data. And then we follow by maintenance with Rapamid for a minimum of 2 years or until disease progression, except for 414 translocation, as they are very sensitive to proteasome inhibitor. And this is our current regimen at Fox Chase: induction, consolidation, followed by maintenance. So I'll switch the gear, it's half an hour already, to autologous stem cell transplant for Hodgkin and non-Hodgkin lymphoma. Talk about Hodgkin, non-Hodgkin, then we must talk about Dr. Hodgkin. This is Dr. Thomas Hodgkin. He was born in England about 200 years ago. And he born into a Quaker family in England. And because he is a Quaker, so he cannot go to Cambridge. He cannot go to Oxford. So he cannot get his MD degree. So he cannot be a doctor if he stay in England. you have to belong to the Church of England to become a doctor in England. So he go to Scotland, he go to Paris in order to get his MD degree. And he was credited, in fact, he's the first brought in a stethoscope back to England from Paris. This is the stethoscope, look at this. This is like a vast. In fact, in his memory, when he brought in the stethoscope, the colleagues is making fun of him, put flowers in the stethoscope, like a vase. This is the stethoscope still in the Guy's Hospital Museum in England. So he got his MD degree in Scotland, in Edinburgh, and appointed the first lecturer in morbid anatomy and museum curator at Guy's Hospital. At that time, pathology basically is doing postmortem examinations and anatomical descriptions. And this is the original paper describing 7 patients with morbid appearance of absorbing glands and spleen by Dr. Hodgkin. We saw a series of patients and with enlargement of lymph glands in the neck, in the mediastinum, and then a spleen enlargement. At that time, the most common cause of lymph gland enlargement are syphilis, tuberculosis, and there's no microscope at that time. They thought this is different. They are in the spleen, and they're a younger patient and has a localization contagiously. So it was described it, and I think it's a different disease. They still think this could be an infection. That's why it's called Hodgkin disease, not Hodgkin lymphoma. No idea about this is a cancer at that time. This is one of the gauze specimens. Again, this can be found still in Guy's Hospital, the mediastinum lymph nodes. Until about 100 years later, and Dorothy Reed and Sternberg, Dr. Sternberg, and they described the microscopic finding of Will Sternberg cells, and this is the cancer cell for Hodgkin lymphoma. So treatment of advanced Hodgkin lymphoma. I'll focus only on advanced Hodgkin lymphoma today because of the time limitation. What have we achieved? I had the privilege being trained by Dr. Joseph Connors at British Columbia Cancer Agency in Canada. In Canada, this is a very tight medical system. That's why it's called British Columbia Cancer Control Agency. It's not cancer center. The goal is to control cancer. At that time, it's not a cure. So Joe Connors and colleagues and Dr. Connors, they have every single patient's data, starting from 1960 for lymphomas. As you can see, for Hodgkin lymphoma, 1960, when he first arrived from United States and went to Canada, after he finished his fellowship at Stanford, most patients with Hodgkin lymphoma died in 1960, better in 1970, 80, 90s. Now is more than 80% patients will achieve a long-term disease control and cure of Hodgkin lymphoma, a highly curable disease. What happened? One is the development of radiation. But with the radiation development, as you can see, is only slight improvement with introduction of the linear accelerator. The breakthrough of improvement in outcome of patients with Hodgkin lymphoma is due to the introduction of combination chemotherapy. And of course, the most important things, on the other hand, is accurate pathological diagnosis. In the old days, many of the patients, in fact, are misdiagnosed. They even don't have Hodgkin lymphoma. When you have an accurate diagnosis, and then you give accurate treatment, a correct treatment, the best optimum treatment for the patient, this results in excellent outcome for the patient. Over the years, starting with MOB chemotherapy, and then with ABVD, and all different escalated BCOP, and this is a war in fighting. And at the end of the day, these two win, ABVD and escalated BCOP. But in the United States, we very rarely use escalated BCOP. So this is escalated BCOP developed by Dr. Volker Dill and colleagues from German Hodgkin lymphoma study group. Basically use every single agent, intensify the regimens with the support with Neupogens. They have shown improvement in the disease control and possibly some overall survival benefit, but multiple agents increase toxicity. Older patients, in fact, tolerating this regimen is very, very difficult. And the mortality associated with this when for older patients and male patients will be becoming more than 80% infertility. As you know, Hodgkin lymphoma affecting much younger patients. This is a major concern with fertility and also with multiple high-dose chemotherapy will lead to second malignancy, leukemia, MDS, and myelodysplasia. So, and also more second malignancy, solid tumor will not develop until you have 10 years, 20 years, and 30 years follow-up. And then cardiopulmonary toxicity, because of all these concerns, this is not widely used in the United States. And there's another reason that we don't use it is because autologous stem cell transplant. It's very interesting when patients have a relapse, metastatic colon cancer and breast cancer, mostly they will die from the disease. The Hodgkin lymphoma being the most chemosensitive and radiosensitive disease. When they relapse, when they have refractory disease, still significant number of patients can achieve a long-term disease-free survival. This is a long-term follow-up from the Spanish data. And as you can see, for patients have chemo sensitive disease, about 50% patient will become long-term survivor after an autologous stem cell transplant. If you can achieve a CR before transplant, even better. So as I said, high dose is better. This is the hypothesis for autologous stem cell transplant. And then this is autologous stem cell transplant followed by stem cell transfer or stem cell rescue. So look at a more systematically comparing BCOP with ABVD. Definitely in this Italian randomized study has shown a better disease control. Freedom from first progression BCOP is better, is about 12%. But a patient who fail can go for autologous stem cell transplant, so ending up the overall survival, there's no difference. And then potentially has less toxicity and less patient will be overtreated. This is important, very, very important, because for ABVD, 75% patient nowadays can achieve a long-term disease control. 75%. If we give this high-dose chemotherapy to these 75% patients, it's not going to help them at all. So we will be over-treating almost 70% of patients. Although the freedom from first progression is better, but many patients doesn't need it. And interestingly, it's continuation, even patients fail autologous stem cell transplant, we can do an allogeneic stem cell transplant using a donor. For patients with Hodgkin lymphoma, still have a good outcome. Why? This is a landmark study showing the acute myelogenous leukemia first complete remission. Identical twin has 60% relapse. Actual identical sibling, only 20%. Why? Because there's an immunological effect. So allogeneic stem cell transplant using a donor, could be a sibling, could be an unrelated donor. There's a very vigorous immunological effect. The new stem cell, new immune system, the new T cells from the donor will recognize the cancer cells and eliminate them. In fact, allogeneic stem cell transplant is the oldest immunotherapy and very effective. Unfortunately, associated with other toxicity. On the other hand, when you look at these data for allogeneic stem cell transplant, this is a big busy slide, but overall this is somewhat effective, associated with significant toxicity. But patients who are refractory, chemo refractory patients, it comes up all the time, failed many regimens. Those are only 8%, in particular those with primary refractory disease, as well as those has poor performance status. The new treatment available is the immunotherapy, in particular like Rituximab, anti-CD30 antibodies with combinations, a chemoconjugate. And most of these patients fail autologous stem cell transplant. And then with this new treatment, about 30 to 40% patient can have a very good outcome. Can this be a cure for the patient if they fail autologous stem cell transplant using brentuximab? So far, the data are limited. In fact, there's only 9 patients in the literature has a long-term follow-up, so we don't know yet. And so I still personally using brentuximab as a bridge for allogeneic stem cell transplant, which allogeneic stem cell transplant has been used for many, many years if patient has a favorable outcome before the transplant. But how about moving brentuximab as for the maintenance then? Again, this is the schema now, the film, not just a stem cell transplant, we have maintenance. We're putting brentuximab into maintenance after autologous stem cell transplant for patients who has poor risk disease, estimated in this group of patients, only 20 to 25% long-term disease-free survival. Who are these people? The patient with refractory to frontline treatment, relapse less than 12 months, frontline therapy, relapse even greater than 12 months, but with extranodal involvement, in particular lung involvement and bone marrow involvement. So they undergoing autologous stem cell transplant, and then starting day 30 to day 45, starting brentuximab. And here show with brentuximab, the 2-year progression-free survival now about 63% in this specific group of patients. So maintenance treatment becoming an important component for patients with Hodgkin lymphoma after autologous stem cell transplant. It benefits all different group of patients. And there's another new kit on the board is the PD-1 blockade. PD-1 inhibitor for patients with Hodgkin lymphoma, and they respond very well. But this is early, only for very refractory disease. And a word of caution, we have limited experience using PD-1 inhibitor for Hodgkin lymphoma, and they may increase acute graft versus host disease after an allogeneic stem cell transplant. And more studies has to be done for this and how to use it wisely in patients with Hodgkin lymphoma. So switch key to non-Hodgkin lymphoma, the most common non-Hodgkin lymphoma. The 2 of them, number 1 is diffuse large B-cell lymphoma. The other one is follicular lymphoma. This is again British Columbia data. CHOP has been used for decades, and our CEO and president, Dr. Richard Fisher, through his landmark study, has made CHOP as the standard of care for patients with diffuse large B-cell lymphoma. And there's no other new treatment and changes until we have the monoclonal antibody rituximab. And this is still the only changes that has made it is adding to CHOP. And this is the population-based study in British Columbia showing that with adding on rituximab after the era as a much improvement in overall survival. In fact, look at rituximab, what it had done to all the B-cell lymphoma. It always improved the outcome by 10 to 15%. So this is the landmark studies published back in 1995, comparing a DHAP chemotherapy versus a autologous stem cell transplant using BEAC, and has shown that a stem cell transplant for chemosensitive disease, about 40% patient can achieve long-term disease-free survival. Interestingly, even with DHAP, there are few patients, about 10%, can achieve long-term disease-free survival. When a subsequent study looked at this specific group of patients, in fact, all these patients that only receive DHAP without a transplant, they have very localized disease. They have stage 1 disease at relapse, small volumes disease, and IPI score 0. So this is a very selected group of patients. Most patients will die with our stem cell transplant when they relapse with aggressive non-Hodgkin lymphoma. So these are the study, this landmark study was performed before the era of rituximab. So what happened when we have rituximab then? So the CORAL studies European and also the US together work on the coral studies and see if what are the changes and what are the best partners before autologous stem cell transplant. And the two regimen uses ICE chemotherapy and DHAP. There's no change. And we cannot find the best regimen with the Rituximab together. But what important information from this study is for patient that has relapsed less than 12 months, patient who had received Rituximab has a horrible outcome. Patient who has a greater than 12 months, even they have received Rituximab before as part of the treatment, again with chemosensitive disease, about 40 to 50% become long-term survivors. So with Rituximab, we select a very bad group of patients. This patient, very few will benefit from autologous stem cell transplant. Can we do it earlier? Earlier may be better in lymphoma. On the other hand, unfortunately, with multiple phase 3 randomized studies, we have not shown really significant difference for upfront transplant for diffuse large B-cell lymphoma. And the Salvage Oncology Group 9704 suggested that maybe the high IPI patient may improve with upfront transplant, but these are less than 10% of patients. And as you can see here, the number is 9704. The study was published in 2011. 9704 means the study started in 1997 and was published 2011. It's almost 20 years. And doing a study reporting, and in between, so many things has changed. So I think autologous stem cell transplant work for relapse patients. It should be better upfronted, but we just don't know how to select the patient. Based on the clinical factor to select the patient, it's just not adequate. That's why there's no big difference. How about allogeneic stem cell transplant? There may be less relapse. Definitely, there's a graft versus lymphoma effect. And interestingly, in one of the retrospective studies from registry, the syngeneic transplant outcome is similar, relapse with allogeneic stem cell transplant, highlighting that a clean graft may be very important. This may account for the difference. That autologous stem cell transplant, high dose therapy, great, but there may be contamination of the tumor cells. So the difference between autologous and allogeneic transplant, both we use conditioning therapy, high dose chemotherapy. There's a graft versus lymphoma effect, none, but there's less toxicity, lower cost, and we push the marrow. No late effect on MDS, there may be late effects of autologous stem cell transplant. So this is a new kid on the board. That's why the title today was Cellular Therapy for Lymphoma and Multiple Myeloma. This is the era of new CAR T-cell therapy, new cellular therapy for patients with heme malignancy. What is CAR? CAR is chimeric antigen receptor. So the immune response depends on T-cell receptor. These are normal T-cell receptor. And this is the engineering receptor, the protein, mimicking T-cell receptor. Look at the components. This is the component that SCFV recognize the tumor surface protein, such as CD19. And there's a co-stimulatory signal and a essential CD3 delta signal in order to have this inserted into the T cells and make it work. So here, well, if we inserted this protein into a T cells, it will stimulate the T cells. At the same time, we're recognizing the tumor protein. Here is a CD19 protein for the B cells, and then and when it's inserted into T cells, they will recognize the tumor cells with the anti-CD19 CAR construct, and then will kill the tumor cells. So CAR T cell basically is a component of, finally, gene therapy is part of the treatment of patients with cancer. The gene therapy, we insert a new component to the cells. Antibody-directed, we have been using Rituximab for many, many years, CD20, now CD19, we insert it into the T cells. Cellular therapy, the T cells. We have been using T cell therapy for many years for allogeneic stem cell transplant, but they're non-specific T cells, has a lot of side effects, and is not target. Now the CAR T cell is a combination of all three of them: gene therapy, antibody-directed therapy, and cellular therapy, and decrease the toxicity, get it out of the shelf, and this is much more effective treatment, potentially could be a breakthrough treatment in the upcoming years. So how do we do it? It's similar to a stem cell transplant, starting with getting the collection of the cells, but this time we only collect the T cells. And then we select the T cells, and then we use a lentivirus, insert the card into the T cells, and then expand in the laboratory. And then we'll prepare the patient with the chemotherapy, fludarabine, and Cytoxan to prevent rejection of these CAR T cells. And then the CAR T cell infused into the patient's body, and then this will be expanded. And expanded, they target the cancer cells and eliminate the cancer cells. So today's topic is lymphoma. So we will do one of the study using CAR T cells from one of the industry partner, Kite, and they have selected a unmethylated chemo-refractory diffuse large B-cell lymphoma patients. These are the definitions of chemo-refractory diffuse large B-cell lymphoma patient: failed autologous stem cell transplant, failed second-line treatment, primary refractory disease. These patients are very, very sick patients, and they are identified from multiple phase 3 randomized study. In a retrospective study we call Scholar-1 has showed these patients, in fact, they are very, very bad. As I have said, the response is only 36% for another line of chemotherapy, with a complete response, complete CR, only 8%. In fact, these patients died within a few months. So, and this group of patients was selected into this first CAR T cell study for diffuse large B-cell lymphoma. These are the eligibility criteria. It's directed to CD19 count. Median age of 58 years old. Decent ECOG-1. Most of them are very refractory disease and failed autologous stem cell transplant. Here you see the SUMO-1. You have a complete remission about 50%. From 8% improved to 50%. I think this is like amazing. And the original study from NCI, in fact, has a few patients at 3 and 4 years. So this is probably becoming a breakthrough treatment for lymphoma, and it also has been shown to be very effective for acute lymphocytic leukemia in children. And there's a CAR T cell program developed in all other heme malignancy and solid tumor. And at Fox Chase Cancer Center, we are working with Kite for lymphoma studies, which will include mantle cell lymphoma, follicular lymphoma, diffuse large B-cell lymphoma. And in the near future, hopefully we will be part of the study for multiple myeloma next year. And then my chairman of hematology oncology, Dr. Adelman, working with Adapt Immune in Philadelphia, developing protocol for lung cancer and head and neck cancer, bladder cancer, and melanoma. And those will be a phase 1 studies. The lymphoma probably will be soon becoming commercially available, as FDA has designated this as a breakthrough therapy, and they need to give an answer to Kite around October this year. And if everything goes well, this will be commercially available in around January 2018, about 8 months from now. And we get all geared up because we are doing a study, and then we are ready to treat CAR T cell patients once it become commercially available, but we also will treat patients if they are eligible for clinical trial. So there's no free lunch. There are side effects related to it. The most significant side effects are called cytokine release syndrome, but they are manageable, and also they have CNS toxicity, about 1/3 of the patient. But these side effects, in fact, are similar to a stem cell transplant. We do it every day. So if we have a careful selection of patient and do it in a bone marrow transplant unit as we plan to do it, then all the CAR T cells will be managed by transplant physician, transplant nurses, transplant pharmacists. This will be a relatively safe treatment. So this is two summary slide, and I only have 5 more minutes. So I'll summarize it. The role of autologous stem cell transplant for lymphoma. Start with Hodgkin lymphoma. No role for upfunded Hodgkin lymphoma. They do so well already. About 75% patients with ABVD will achieve a cure already. So no role for upfunded transplant at all. And this is very strong for chemo-sensitive relapse, second CR. We can give the patient a second chance. Again, about 50 to 60% patient minimum will have a long-term disease-free survival for a autologous stem cell transplant. If they achieve a PET negative state before autologous stem cell transplant, up to 80% patients will become long-term survivor. Advanced disease, less well, but Hodgkin lymphoma is the most chemosensitive and most radiosensitive disease. Even with advanced disease, and in particular in combination with maintenance treatment, this still work for patients, even sometimes with chemo-refractory disease. As per NCCN guideline and also our practice, we treat mantle cell lymphoma upfronted with autologous stem cell transplant, prolonged survival, prolonged progression-free survival. We have patients with more than 10 years, 15 years after autologous stem cell transplant for mantle cell lymphoma. Relapse not as good. We routinely transplant patients with peripheral T-cell lymphoma at first remissions, as these patients has a very aggressive disease course, again for chemo-sensitive patients. But for advanced disease, for mantle cell lymphoma, peripheral T-cell lymphoma, it's unlikely that they will benefit from autologous stem cell transplant. They have to do it early. Diffuse large B-cell lymphoma, this will be very, very selected patient with multiple pool risk factors by IPI. And for upfunded transplant at first complete remission, strongly indicated for chemo-sensitive relapse, less for advanced disease. Follicular lymphoma is a comeback kit for early patients who relapse with follicular lymphoma. Autologous stem cell transplant has shown to have a durable long-term response. According to the report from City of Hope National Medical Center from Los Angeles, Stanford University, as well as from Nebraska. And there's about 30% patients that have a first or second complete, the first relapse, second relapse, and chemo-sensitive disease going for a transplant, and they have like 15 years long-term survival, about 25 to 30%. So follicular lymphoma, autologous stem cell transplant work for selected patients. Burkitt, I give 1+, as this is a very aggressive disease. It works in literature. Burkitt is a very uncommon disease, but the patient has such a rapidly progressive disease, most of them can never even come for a transplant. The modern treatment, in fact, is very effective with hyper-CVET or Codox-M, so note indication as first CR. So very limited patient can benefit from a transplant for Burkitt. Allogeneic stem cell transplant, advanced disease, because they have a graft versus lymphoma effect. I can show you in this slide that who has the strongest graft versus lymphoma leukemia effect in this setting. Hodgkin, in fact, a strong one. That's why the PD-1 inhibitor work, the immunotherapy work for Hodgkin lymphoma. Follicular lymphoma work very well because overall Hodgkin, follicular, CLL, SLL, they're slow-growing disease. In order to use allogeneic stem cell transplant as an immunotherapy, you need time for the immune system to work. So if a patient has rapidly progressive disease, it doesn't work. You have to be a less aggressive or get a better control of disease before the patient coming for a transplant. And the best one is CLL, SL, follicular. Mantle cell lymphoma is also a good one. Diffuse large B-cell lymphoma, peripheral T-cell lymphoma has a limited graft versus lymphoma effect. And certainly we'll consider patients who failed autologous stem cell transplant for Hodgkin's, follicular, and CLL for a allogeneic stem cell transplant. but very few patients has ever been transplanted using autologous stem cell transplant for CLL and SLL has been shown not to be very useful. So this is 2 more minutes. Conclusion. Accurate pathological diagnosis is the key to the success of treatment of lymphoma. We must have an accurate pathological diagnosis. Autologous stem cell transplant, allogeneic transplant are effective treatment for patients with lymphomas, multiple myelomas. All lymphoma patient, myeloma patient are potential candidate for stem cell transplant, but not all patients with lymphoma will benefit from a transplant. Graft versus lymphoma, immunologically mediated effect contributes significantly to the success of allo transplant for lymphoma. Incorporating target therapy into treatment strategic may increase eligible patients for stem cell transplant, improve transplant outcome, and overall outcome for lymphoma patients. And there's evolving role for post-transplant consolidation maintenance for lymphoma patients. Of course, there's an evolving role for CAR T therapy for patients with diffuse large B-cell lymphoma, and we have active studies for mantle cell lymphoma and follicular lymphoma, and hopefully this will be a new treatment modality, and more patients will achieve a durable response with the combination of all the available treatment for them, and achieve a cure of all their lymphoma, and they will have a happy face. Thank you very much for your attention. It's